Good evening, everyone, and welcome to tonight's webinar. My name is Monica Uceda, I'm an R2 at St. Francis Hospital in Evanston, Illinois, and current chair of the Women in IR Committee for the SIR-RFS and Fellow section. This is the first webinar of the new term organized by the Women in IR Committee. Our mission is to inspire, educate, and promote women in interventional radiology. If anyone in the audience is interested in getting involved in our committee, please do not hesitate to contact us. Also follow us on Twitter at WomenIRATS. I am honored to have the opportunity to introduce Dr. Geetika Klevos. Dr. Klevos is the Chief of Breast Interventional Oncology and Assistant Professor of Clinical Radiology at the University of Miami-Leonard Miller School of Medicine. She completed her residency and both fellowships, interventional radiology and breast imaging, at the same institution. She also serves on the University of Miami Medical Group Council. She has authored and co-authored several research publications, including her work in treatment of metastatic colorectal cancer with drug-eluting beads, irreversible ectroporation for pancreatic cancer, and image-guided cryoablation of breast tumors. I attended Dr. Klevos' presentation on cryoablation of breast tumors during the last Synergy meeting, and I was impressed with this state-of-the-art procedure. More so, I was deeply inspired by her patient-centered approach and her genuine care for women's health. Without further ado, please welcome Dr. Geetika Klevos.
Hello, everyone. Welcome. I'm really excited to be here today and talk to you about this innovative, minimally invasive treatment modality, namely cryoablation for breast tumors. I would like to thank SIR for this wonderful opportunity and for creating this webinar and platform where we can all have a conversation about breast cancer and exciting, effective treatment modalities that are rapidly evolving, which we can use as tools in our armament in the fight against cancer. So without further ado, let's get started. This is a slide to give you an overview of my presentation. We're going to start with an introduction and background about cryoablation, the research and clinical studies that have been done so far, followed by some current trials that are underway. Next, we're going to talk about some details about the procedure itself, who the ideal candidate is, and what the advantages of the procedure are. I will then present some data on animal studies we performed at the University of Miami, moving on to show some ultrasound-guided procedures done in patients with symptomatic benign fibroadenomas at our institution, as well as a cancer case that was treated at a community hospital. And finally, a conclusion slide to tie it all together. One of the most promising areas of current interventional research is the development and validation of image-guided ablation as a non-surgical, minimally invasive treatment modality for breast tumors. Cryoablation is emerging as a minimally invasive approach in the treatment of breast cancer by minimizing the cosmetic and functional impairment of the breast resulting from volume and sensation changes, nipple displacement, and scar formation and retraction due to surgical resection. The main factors driving ablation for breast tumors are early detection due to increased awareness and aggressive screening measures, increasing survival of breast cancer patients with a renewed focus on cosmetic and functional outcomes, and decreasing size of breast cancer on presentation, again, owing to improved and widespread screening. In many ways, if you think about it, the breast is the perfect organ for ablation. It's covered only by skin with no intervening structures. The breast tissue can be compressed quite asymmetrically to achieve strategic skin-to-lesion geometries, and it can be imaged effectively with ultrasound, making it very accessible. Although breast conservation therapy allows mutilation to be avoided, the rate of negative cosmetic results after lumpectomy performed by means of a wide excision can be as high as 30%. Ultrasound-guided cryoablation is an appealing alternative to surgical resection because it's office-based, it has intrinsic analgesia, therefore it can be performed without sedation under local anesthesia, it's inexpensive relative to operative procedures, and cosmetic outcomes are excellent. Now, the clinical model for cryoablation of breast cancer is derived from the office-based cryoablation of fibroadenomas, which has been in practice since 2002. That's when it first got FDA clearance. Complete clinical disappearance of a fibroadenoma occurs within 1 year of treatment in 95% of patients, as shown by Kaufman et al. Initial experience with cryoablation for breast cancer centered on palliation of locally advanced disease. Cryoablation has been done in elderly patients with non-resectable breast cancer with no recurrence reported at 18 months. Now, most of the available studies of cryoablation for breast cancer dating as far back as 2002 were followed by surgical resection. I apologize that this is a busy slide, but I promise you it looks worse than it is. The point of this slide is to show you how the findings and conclusions of these studies have helped shape the parameters of the trials occurring today. Fliederer and colleagues in 2002 in Germany treated 16 tumors ranging in size from 0.9 to 4 centimeters under ultrasound guidance. Given some of the larger tumors, the overall complete ablation rate was only 31%. However, now this is where it gets interesting. The investigators reported that for tumors smaller than 1.6 centimeters, the ablation was 100%. This was later confirmed by them in 2005 in another study done in 29 patients. Following this, Sable and colleagues from the United States in 2004 showed a success rate of 100% for tumors smaller than 1.5 centimeters if patients with lobular carcinomas and patients with an extensive intraductal component were excluded. Morin et al. Performed cryoablation, but this time under MRI guidance instead of ultrasound guidance. Now, this study showed the ability of MRI combined with symptomammography to predict the histopathologic results with an accuracy of 96%. Finally, Manenti and colleagues in 2011 treated lesions up to 1.2 centimeter in size and showed complete ablation in 93% of patients. So to summarize, cryoablation seems to work well for smaller tumors measuring up to 1.5, 1.6 centimeters. It works well for invasive ductal cancer, not so much for invasive lobular cancers or those tumors with an extensive intraductal component. An MRI can be used with some degree of precision to predict recurrent or residual disease. Building upon these findings, in 2008, the American College of Surgeons Oncology Group, the ACOSOG, launched a phase 2 trial exploring the success of cryoablation therapy in the treatment of invasive breast cancer. This was called the ACOSOG Z172 trial, which completed accrual of 100 patients. This clinical trial, the largest to date, 100 patients, 20 clinical sites, was designed to determine if cryoablation can be successful in ablating stage 1 tumors. The primary endpoint of the study was the rate of complete ablation. Now, 100% of the tumors up to 1 centimeter and 94% of the tumors up to 2 centimeters showed complete ablation, which was confirmed at the time of lumpectomy by histopathology. This is an MRI sagittal image showing a heterogeneously enhancing mass with washout kinetics, and a post-cryoablation MRI on the right showing no enhancement in the area. The Z1072 trial was a National Cancer Institute-sponsored clinical study led by Dr. Rach Simmons, the chief of breast surgery at the Weill Cornell Medical Center in New York City. Dr. Simmons commented about the trial that compared to surgery, cryoablation is far less invasive, provides better cosmetic results, has a shorter procedure time, and faster recovery. Now, there are 2 studies that have looked at cryoablation alone without surgical resection. The first one was performed by Littrop and colleagues, where they treated 22 lesions in 11 patients who refused surgery. With a mean follow-up of 18 months, there were no local recurrences. The second study series was performed by Dr. Eisuke Fukuma in Japan since 2006. He has conducted clinical studies employing the use of cryoablation as an alternative to surgical resection of luminal type A invasive ductal cancers n equal to 22, or hormone receptor positive DCIS n equal to 16, measuring up to 1 centimeter. Resection of the primary tumor was not performed, but sentinel node biopsy was mandatory. In addition, all patients underwent subsequent whole breast external beam radiotherapy followed by adjuvant endocrine therapy. All patients were monitored post-cryoablation with semiannual or annual mammography and contrast-enhanced MRI. At a median follow-up of 43 months, no local regional or distant metastases were observed, and cosmetic results were excellent. 33 additional patients underwent cryoablation, followed by vacuum-assisted biopsies of the cryoablated zone 1 to 2 months post-cryoablation. Histopathologic analysis of the breast biopsies revealed no residual viable tumor cells in the ablated zone. I would now like to talk about some current studies that are underway. The study I would like to present to you is the FROST trial, which stands for freezing instead of resection of small breast tumors. It's a multi-center, non-randomized trial to be done in the United States with 40 different centers with a goal to accrue a total of 200 patients. Cryoablation will be used as an alternative to surgery for malignant tumors measuring up to 1.5 centimeters. Like I said, it's a multi-center, non-randomized study for biopsy-proven clinical stage 1 T1 up to 1.5 centimeter tumors, clinically node-negative, unifocal, ER/PR positive, HER2/neu negative invasive ductal cancers. It is currently recruiting participants, and University of Miami hopes to be a prospective center. Post-ablation biopsy at 6 months will be performed to confirm successful tumor ablation. Adjuvant endocrine and/or chemotherapy during the trial will be allowed for control of systemic disease. Patients will be divided into 2 strata. Stratum 1 includes low-risk patients, age 70 and older. Now, this is based on the CA-LGB 9343 trial, where the addition of radiation, as we already know, was challenged in patients receiving lumpectomy and tamoxifen. Clinical stage 1 T1 up to 1.5 centimeter N0 tumors, invasive ductal cancer with an in situ component not exceeding 25%. ER/PR positive, HER2/neu negative, luminal type A cancers, where cryoablation will be followed by a 5-year course of endocrine therapy. No lymphadenectomy, breast radiotherapy, or surgical resection will be performed. Radiation and axillary staging are not mandated by protocol, but will be allowed based on individual study site policy. Stratum 2 includes moderate risk patients, ages 50 to 69. Again, clinical stage 1 T1 up to 1.5 centimeters, N0, M0 tumors, invasive ductal cancers, ER/PR positive, HER2/neu negative, where cryoablation will be used instead of lumpectomy, but in addition, all patients will receive whole breast radiotherapy and systemic therapy, including a 5-year course of endocrine therapy. All patients successfully completing cryoablation will be advised to receive conventional whole breast radiotherapy using standard tangential fields and a tumor bed boost. Radiotherapy is to be initiated within 2 months of completing cryoablation. If chemotherapy is indicated, radiotherapy should be initiated within 2 months of completing chemotherapy. Hypofractionation and partial breast radiotherapy will not be allowed following cryoablation, but may be permitted if a subject is required to undergo complete resection of the tumor site. Sentinel node biopsy is not mandated by protocol, but will be allowed based on individual study site policy. The primary objective of this trial is to determine the rate of successful tumor ablation in patients treated with cryoablation of the primary tumor instead of surgical resection. Successful tumor ablation will be defined as the absence of residual viable, invasive or in situ carcinoma detected by core needle biopsy of the ablated zone done at 6 months after cryoablation. Residual viable disease will require surgical therapy, either lumpectomy or a mastectomy. Secondary objective is to determine ipsilateral breast tumor recurrence rate, to document breast cosmesis, and to document adverse events. This is the inclusion criteria for stratum 1. The main points, again, unifocal IDC, age more than 70. Now, other special type of tumors like mucinous and tubular type may be allowed on a case-by-case basis based on the imaging features and tumor biology. Clinically node-negative patients based on exam and axillary ultrasound, or histologically confirmed negative nodes based on fine needle aspiration or core needle biopsy of the axilla. Those tumors with a less than 25% intraductal component in the aggregate. The breast size should be adequate, with 1 centimeter margin for safe cryoablation, and at least a distance of more than 3 millimeters from the chest wall or muscle. Inclusion criteria for stratum 2 or moderate risk is similar, except for the age criteria, which is 50 to 69. Exclusion criteria for stratum 1, prior open surgical biopsy or lumpectomy for diagnosis or treatment of the index breast cancer. Multifocal or multicentric invasive breast cancer is an exclusion criteria. DCIS with microinvasion, microcalcifications extending more than 5 millimeters beyond the ultrasound visible mass, or multifocal calcifications. Poor visualization of the tumor by ultrasound, that is, no clear lesion by ultrasound or maximal dimension by MRI, more than 25% larger than the maximal dimension by ultrasound. Prior or planned neoadjuvant systemic therapy for cancer is also an exclusion criteria. Exclusion criteria for stratum 2 is similar, barring the age. Coming to the study design of the FROST trial, bilateral breast MRI at 6, 24, 36, and 60 months post-cryoablation will be performed, with optional MRI options at 12 and 48 months. Unilateral mammography and unilateral ultrasound of the cryoablation zone in the ipsilateral or treated breast and axilla will be performed semi-annually post-cryoablation. Mammography of the contralateral or the untreated breast and axilla will be performed on an annual basis. Receptor status and other tests, including oncotype, will be performed on the initial biopsy specimen for diagnosis. Breast cosmesis will be assessed by comparison of the pre- and post-cryoablation breast appearance and function using bcct.core, which stands for Breast Cancer Conservation Treatment.Cosmetic Results. It is a software program that provides an objective tool to quantify the aesthetic results of breast-conserving surgery, discriminating between 4 categories of excellent, good, fair, and poor of overall subjective evaluation. Breast cosmesis will be assessed at baseline, 1 year, 2 year, and 4 year post-cryoablation. This is just a schematic showing the trial. So who is the ideal candidate for cryoablation? Well, patients with a lesion size up to 4 centimeters for benign tumors and up to 1.5 centimeters for malignant tumors with a DCIS component not exceeding 25%. At least 3 to 5 millimeter of space between lesion and surface of the breast is desired. Patients who are not good candidates for surgery and/or general anesthesia because of comorbidities or anxiety. And, of course, patients concerned about cosmesis. Let's talk about some of the advantages of cryoablation. One of the big advantages is that cryoablation has been known to induce a tumor-specific immune response stimulated by damaged cells, which may contribute to controlling distant systemic metastases, which is really exciting. As opposed to the protein denaturation seen with heat-based ablations, cryoablation allows for a massive antigen presentation to the host immune system in the form of an in situ personalized cancer vaccine. High-freeze cryoablation in mice generated a tumor-specific immune response with eradication of systemic micrometastases and reduced the tumor recurrence rate compared with results of surgical excision. Other advantages include that it's office-based, therefore it can be performed in an outpatient setting, it's inexpensive relative to operative procedures, it's minimally invasive with excellent cosmetic outcomes, and finally, the ice has intrinsic analgesia. The procedure therefore can be performed without sedation under local anesthesia on an awake patient. The non-surgical, minimally invasive aspect of tumor ablation is particularly attractive given the ongoing controversy about the overdiagnosis and possible overtreatment of potentially indolent breast cancer. Cryoablation may be the optimal compromise that balances the goals of early detection and treatment of aggressive cancers with the desire for a less invasive and less morbid approach to managing potentially non-aggressive breast cancers. Coming to some details about the procedure. Cryoablation is performed by placing a cryoprobe at the center of a tumor. A cryoprobe is a high-pressure, closed-loop gas-based system using liquid nitrogen or argon. Now, liquid nitrogen systems work on a single probe mechanism and induce freezing evenly throughout the tip surface, resulting in larger ablation volumes and faster treatment times. Argon systems work on a Joule-Thomson effect, where rapid expansion of gas results in change in temperature of the gas. Target freezing temperatures of -190 to -160 degrees Celsius are achieved. Freezing causes cell death owing to extracellular and intracellular ice formation, altered tissue osmosis, cell membrane damage, and lysis. Freezing also damages the vessels feeding the tumor, leading to anoxia. The equipment used at the University of Miami includes the Vesica 2 treatment system from Cenaris, which uses liquid nitrogen. Local anesthesia is given and ultrasound imaging is used to locate the tumor. The ice probe is placed percutaneously through a small 3 mm incision. A freeze-thaw-freeze cycle ensues and a controlled ice ball is formed, which fully ablates the tumor in situ. The probe is subsequently removed and a small sterile bandage is applied. The tissue is naturally resorbed over time. The total procedure time is approximately 30 to 40 minutes with the patient supine in a comfortable position with a recovery time of less than 1 day. During freezing, saline can be injected between the ice ball and the skin to prevent skin damage if the ice ball rim is within 5 mm of the skin. This enables safe treatment of cancers that are close to the skin, unlike heat-based ablations. What are some things to discuss with your patient before you do the procedure? You have to tell them that the lesion will get bigger before it gets smaller, and previously non-palpable lesions will become palpable. The tumor will be palpable for many months, but will disappear in about a year. Post-procedure bruising is expected in the area, which may take up to 1 week to resolve. Pain is minimal, but may be experienced transiently in some patients with deeper lesions, especially those resting on the pectoralis muscle. In these patients, medications may be prescribed for pain control in the days following the procedure. Moving on to some data from animal studies performed at the University of Miami, there were 7 ablations performed in 4 Yorkshire pigs. Please note that these pigs did not have breast cancer. The ablations were performed in fibrofatty tissue to simulate breast tissue. Proposed lesion size ranged from 1 to 4 centimeters. MRI scans with and without contrast were performed on day 1 and 3 of ablation. The pigs were euthanized on day 3, and the tissue was harvested and sent for histopathologic analysis. This slide demonstrates the ablations performed at varying distances from the skin. This slide shows the ablation that was deliberately performed close to the skin surface to demonstrate the freezer burn. The gross specimen on the right shows the ice ball extending to the surface of the skin. The H&E stains demonstrated architectural preservation of the ablated area with central coagulative necrosis showing ghost nuclei and indistinct cellular borders. The top left is the control. On the bottom right, you can see necrosis in the cryoablated zone with inflammatory cells in the surrounding viable tissue. So the real question is, was the ablation successful? The nicotinamide adenine nucleotide stain performed to evaluate metabolic activity was negative, demonstrating cell death. And as per the pathologist's report, there was uniform necrosis with no viable tissue seen throughout the ablation zone. The top left is the control. On the bottom right, you can see loss of normal architecture and lack of staining consistent with no metabolic activity. This is an MRI pre- and post-contrast image showing no enhancement in the cryoablated zone with a thin rim of peripheral enhancement on the right image, which is normal and it's called the cryohalo. Coming to some cases we performed at our institution on benign tumors. This patient presented with a painful biopsy-proven fibroadenoma. Her tumor measured about 2.8 centimeters. It was a deep lesion resting on the pectoralis muscle, as you can see. On the bottom right image, you can see the cryoprobe going through the tumor. This demonstrates the formation of the ice ball in the sagittal and transverse planes. The 1-month post-follow-up ultrasound shows the tumor shrinking in size. It now measures 2.6 centimeters. One thing you should discuss with your patients is that the tumor will get bigger and more palpable, like I mentioned before it gets smaller. But over the course of 1 year, it should completely disappear. I actually had this patient come for a 6-month follow-up, and a tumor measures 1.6 centimeters now, so it's almost become half of where we started off with. This is another patient who presented with a symptomatic fibroadenoma measuring 2.2 centimeters. You can see in the bottom right image the cryoprobe going through the center of the tumor. Care should be taken to secure the tumor through the geometric center as much as possible, which can be confirmed on the transverse top left image, as you can see. This is important to ensure uniform ablation by the ice ball all around the tumor. Next, you can see the formation of the ice ball in the sagittal and transverse planes. As you can see, the ice ball has a discrete hyperechoic rim, which is what you want to look for. Only the anterior rim is visualized. The posterior rim is obscured due to shadowing, which is normal. The 1-month post-procedure ultrasound shows the tumor shrinking in size. It now measures 2 centimeters. I would now like to talk about a cryoablation case which was performed for biopsy-proven cancer. This was a 76-year-old female with a history of right breast cancer, status post-mastectomy. She also went on to develop a left breast cancer, which was treated with lumpectomy, radiation therapy in an axillary lymph node dissection about 10 years ago. She presented for a routine annual screening mammogram in August of 2016, and a new left breast mass was found. All studies were performed at a community hospital in Miami. This is a mammogram CC and MLO image of the left breast, where you can see post-treatment changes in the upper outer quadrant. Otherwise, it looks negative. This mammogram is from 2013. Her mammogram from 2016 shows the post-treatment changes in the upper outer quadrant, but in addition, now she has developed a mass at the 11-12 o'clock axis. This is a spot compression image, better delineating the mass. This is an ultrasound correlate for the mass. The mass was biopsied under ultrasound guidance. Pathology yielded encapsulated papillary carcinoma. Patient declined surgical management, so cryoablation was offered and she consented. You can see the cryoprobe going through the tumor, formation of the ice ball in the transverse and sagittal planes. 3-month follow-up mammogram showed no residual mass. You can see the post-cryoablation mammogram from January of 2017, where you can see the post-treatment changes in the upper outer breast, and there's a biopsy clip at the 11-12 o'clock axis where the mass was previously seen, but now you don't visualize the mass. And this is a spot compression image, again, just showing the biopsy clip with the mass no longer visualized. So to conclude, cryoablation is a minimally invasive treatment modality for breast cancer with a distinct advantage of potentially obviating the need for surgery in a select subset of patients and thereby resulting in improved cosmetic outcome. It can be performed on an outpatient basis under local anesthesia with little to no recovery time. It is cost-effective compared to surgery, $3,000 per probe, which can be billed to insurance, as opposed to lumpectomy, which can cost up to $11,000. The best clinical results are achieved when small, up to 1.5 centimeters, luminal type A cancers are treated with an in situ component not exceeding 25%. My vision is to make cryoablation a standardized treatment in breast cancer therapy. Now, make no mistake about it, cryoablation is not for every patient with breast cancer, but it can be very successful in the carefully selected patient. The FROST trial will hopefully pave the path to establish this as a standard of care, so women can feel more confident and comfortable in their own bodies in spite of having had an encounter with breast cancer, where we don't have to stick to the archaic treatments of cut or poison when it comes to cancer, so that women can think of breast cancer as a small blip in their journey through life and not as the life-changing event that it currently is. Thank you. I welcome any questions you may have.
If you have questions, feel free to submit them in a question box and we can go through them one by one.
I have a quick question, Dr. Klevos. What are the characteristics in follow-up studies, either in MRI or ultrasound, that would make you suspicious of failure in malignant tumors, considering that there is an increased in size effect right after treatment?
Sure. So under MRI, it becomes very easy to look for, what we look for is residual enhancement, especially if you see nodular enhancement where the tumor is. For under ultrasound, it's a little bit more challenging initially because in the 1-month follow-up ultrasound, when I did it for the fibroadenoma patients, there was no increased vascularity, so that's the one thing you look for, but the tumor size will be increased and you'll see a lot of swelling in the surrounding tissues. But enhancement on MRI and increased vascularity is what we go by. So as long as we don't see those two things, you can be assured that the tumor is not coming back and was treated adequately and effectively.
Thank you.
Sure.
How long would you say you would wait? I mean, according to your lecture, you have a follow-up up to 48 months. Is that correct?
Yes.
So if you see some suspicious characteristics, do you stop? Do you wait? Like, how do you gauge the time especially for malignant tumors?
Sure. So in the FROST trial, they're very clear about it because this is the first trial of its kind where cryoablation will be performed and no surgery will follow the cryoablation procedure. So say in the follow-up MRI, which is performed at 6 months or 12 months, there is some residual enhancement seen in the area which looks suspicious. The first step would be to confirm that this is recurrence or residual tumor behind. So you do a biopsy. And if on the biopsy the pathology shows residual viable cells, tumor cells, in that case the patient will either go on to have a lumpectomy or a mastectomy.
So we have two submitted questions. Is there any data comparing the technical efficacy of ultrasound-guided versus MRI-guided ablation?
No, I think the studies that have been done so far using MRI, the largest study series was done by Dr. Eisuke Fukuma in Japan. He used MRI and ultrasound, so his data would be the most, but he hasn't quite published it yet. The Z172 trial, the procedures were done under ultrasound guidance, but the follow-up was done under MRI guidance. I don't think they placed any probes under MRI guidance, though I know that that's an option for patients if they and for clinicians if they want that. But as far as answering your question goes, if there's any data comparing the efficacy of two, I think both should be pretty comparable. I personally would prefer to do it under ultrasound rather than MRI because ultrasound just offers that ease of the procedure for me and for the patient because the patient's lying supine for the ultrasound procedure. For MRI, they would have to be prone and it just gets more uncomfortable for the patient.
And our second submitted question is, do you ever perform repeat freezes or are all of these cases treated with single freeze?
So we use liquid nitrogen system at the University of Miami, and that's a single probe, single freeze system. I mean, there are 2 freeze cycles per treatment. So, but if that treatment fails, you won't go back and freeze again. But it is a freeze, thaw, freeze cycle. So there's 2 freezes and 1 thaw within the same treatment time. Does that answer your question? Hello?
Oh, it was a question submitted by
I see.
Edwin.
Okay.
Sorry.
Yeah, no, so we don't go back and, we won't do another treatment on the patient if the first one fails.
Great, thank you.
Sure.
How do the patients go about insurance? Is this, I'm not sure, is this covered by insurance yet? And how do they go about it as of now?
Sure, that's a great question. And, the FROST trial kind of detailed that very clearly. The costs of the cryoprobe will be covered by the sponsor. So when the patient comes in, with the initial diagnosis of breast cancer, everything up to the point of cryoablation should be covered by insurance because it's standard of care. So whether she is to go for lumpectomy or, cryo, you would still do the biopsy, initial biopsy. The specimen will be sent to pathology for a diagnosis. Once she has a diagnosis, she will then either come to us for a consult of cryoablation, or she would have gone to the surgeon for a consult for lumpectomy. If she comes to us for cryoablation, the professional and technical fee would be covered by the institution. The cryoprobe cost would be covered for by the sponsor, and the MRI, the follow-up MRIs, because this is part of a trial, the 6 month, 12 month, and 48 month, 48 month would be covered by the sponsor, and the optional 24 month and 60 month MRI would have to be paid for by the patient's insurance. Most of the time, the insurance companies don't deny coverage to these patients, but before we do anything, any test or even the procedure itself, we always get pre-authorization from insurance to make sure that the patient doesn't get slapped with a bill later on, or it comes as a surprise to them. So we always get pre-authorization. Even for when I did the symptomatic fibroadenoma cryoablations.
And we have another submitted question. What is the best training pathway to gain the skills needed to perform these ablations? Breast imaging or IR?
That's a tough one. You can do either or. Now, I think the answer to that question really lies on what your institution follows, because in some institutions, cryoablation, IR does cryoablations for all other organ systems already. And in some institutions, breast cryoablation, because it's an interventional procedure, it would be covered by IR. But in my institution, because I have the dual skill set of being fellowship trained in both, the chair of IR actually approached me and asked me if I wanted to do the cryo, and of course I said I would love to. And so that's how it got channeled to the breast imaging section. But I am the only one currently in my section to be doing the cryoablation procedure. The other breast imagers, they do the biopsies and everything else, but they haven't started doing the cryo. They hope to get trained, you know, eventually down the line once the FROST trial takes off. But I think you can do it either way, either breast through a breast fellowship or an IR fellowship. But I think what would be most important, what was most helpful for me initially, was to actually go to a facility where they were doing cryo, and I saw a physician actually do a case, because that just adds a whole dimension of, you know, nuances which you need to pay attention to, but you wouldn't know if you're just reading a book or, you know, looking at a video or something like that. So that was really helpful. And the other thing that really helped me personally was the pig experiments, because I actually got a feel for what it feels like. And, you know, when you're doing it, whether it's a pig or a human, you actually get a feel for the procedure itself. So.
Great. And another question submitted by an audience member. How does a cryoablation perform for tumors close to the chest wall, given that we can't typically see the posterior rim of the ice ball on ultrasound?
Sure. So, you know, as long as you can, even for deeper lesions, like if you remember one of the slides I showed for the symptomatic fibroadenomas, that tumor was resting right on the pectoralis muscle. So as long as you have access to actually go through the center, to place the cryoprobe through the center of the tumor, you can be assured that the ice ball is going to engulf it from all sides, even though you're not able to visualize the posterior rim. So the technical challenge in that case would be only your ability to skewer the tumor through the center with the cryoprobe. As long as that is accomplished, there should be uniform ablation, even though you can't see it.
Great. And one more question. Would you advise not treating malignant lesions less than 1.5 centimeters at this time, and wait on the results from the FROST trial?
Less than 1.5 centimeters or more than 1.5 centimeters?
The question that was submitted was less than.
So less than 1.5 centimeters lesions should be, the FROST trial says you can treat lesions up to 1.5 centimeters. And the challenge of whether cryoablation is effective or not is actually for the bigger lesions, because the freezing temperature is coldest towards the center of the tumor where the probe is. And as the distance from the probe increases, that means the tumor is getting bigger, then, you know, the freezing zone actually decreases in efficacy, if that makes sense. So for treating smaller lesions, it should be no problem at all. It's when you want to treat lesions, malignant tumors that are actually bigger, like 3 centimeters or something, I would be hesitant doing that without actually having the results for the FROST trial. In the Z172 trial, they treated lesions up to 2 centimeters, and it showed 94% complete ablation in those lesions, even up to 2 centimeters. So you can, I would be comfortable treating lesions up to 2 centimeters easily with cryoablation for malignant tumors. But for purposes of the FROST trial, the size they are restricting the trial to is 1.5, up to 1.5 centimeters. So 1.5 centimeters and smaller.
Great. Thank you so much for answering all of our questions.
Sure, of course.
Sorry, I have one more question. Would these results apply to male breast tumors?
Sure, yeah. Male, female, you know, if there's a malignant breast tumor, it should work. With the male breast cancer, the only thing I would say you have to be a little careful about, because males typically don't have a lot of breast tissue, so you would have to make sure, you know, the tumor is adequately placed in the breast tissue, meaning there's adequate amount of breast tissue above the tumor and the skin. We say at least 5 millimeter of distance should be there to prevent the freezer burn, which I demonstrated in the slides on animal studies. But there are ways you can increase that distance. You can actually do hydrodissection and give a, you know, inject saline between the skin and the lesion to increase that distance, and you can perform cryo then. But as far as efficacy, yes, it should definitely be effective even in male breast cancer.
All right. Do you guys have any more questions? I don't see any more questions, Maggie.
Nope.
All right.
All right. I think, yeah, we'll wrap it up at this point.
Well, thank you both again for this opportunity. This was really wonderful.
Yes, I wanted to
thank you so much for having.
Being able to do this is really helpful for everyone. Thank you very much, Dr. Klevos.
You're very welcome.
All right, thank you everyone for joining us this evening. Tonight's webinar will be available online if you would like to review the slides at a later time. Thank you everyone. Dr. Klevos, are you able to end the recording on your end, I think, because you're currently the presenter.
Oh, I don't see a button.
It should be in your control panel.
I see it's recording, but I don't see a stop button, or I mean, the pause button doesn't